Hello everyone. This is the second part of complications of cardiac catheterization. The other two complications than atriovenous fistula of cardiac catheterization is iatrogenic pseudoaneurysm and hematoma. The Uworld ID for this question is 12282. So the iatrogenic pseudoaneurysm, first of all, is a false aneurysm and it's due to the localized arterial damage in which the intima is damaged, the hemostatic plug or the hemostasis is incomplete, which causes the blood to flow into the arterial wall, though it do not go into the surrounding tissues and is surrounded by the periarterial connective tissue that forms a pseudoaneurysm. The most common site of the pseudoaneurysm is femoral artery after cardiac catheterization, though it can also be formed in other parts of the body like radial artery. Now it is very important to know that the majority of them forms within the first 24 hours after sheath removal, and then the other half in the first 3 days. And the risk of iatrogenic pseudoaneurysm increases if the patient activity increases after cardiac catheterization, as activity decreases the risk of effective hemostasis, and that's why after cardiac catheterization the cardiologists advise bed rest. Now there are well described risk factors for iatrogenic pseudoaneurysm. Now if the board asks many risk factors, so it's important to remember that the main risk factor for pseudoaneurysm formation after cardiac catheterization is inadequate period of manual compression. The reasoning behind this is that after cardiac catheterization, manual compression is very important to make sure that adequate hemostasis is achieved. But if the manual compression is not done, there is increased probability for the blood to seep into the wall of the artery, which increases the risk of pseudoaneurysm formation. This is the most important and the most common risk factor for pseudoaneurysm formation. The other risk factors for pseudoaneurysm formation is a female sex, increasing age like more than 65 years, if there's hypertension as there is more pressure in the arterial walls, which facilitates the blood to go into the arterial wall, if there are severely calcified vessels. It's also very important to know that pseudoaneurysm risk increases if there is inadequate coagulation or inadequate platelet function. That can happen in end-stage renal disease as uremia inhibits platelet aggregation, which leads to abnormal platelet plug formation. If there is antiplatelet drugs that are taken like clopidogrel aspirin, it also increases the risk of pseudoaneurysm formation. Similarly, anticoagulation, it decreases the chances of developing a good hemostatic plug, and it increases the risk of pseudoaneurysm formation. Another important incidence of pseudoaneurysm formation has been reported the people in which a larger sheath size is used, that is more than 6 French, and is more prevalent on the left femoral artery compared to the right femoral artery. Now it's very important to clinically pick a pseudoaneurysm. So whenever there is a pseudoaneurysm, it causes a systolic bruit compared to a continuous bruit in atriovenous fistula. Second, pseudoaneurysm causes a pulsatile bulging mass. This pseudoaneurysm can cause groin pain, swelling. Very important thing to know is that if the patient has the risk factors for pseudoaneurysm and patient undergo cardiac catheterization, but there is an absence of bruit, it do not exclude pseudoaneurysm. Very important to know that. Now, how a pseudoaneurysm can be complicated. The first and the foremost thing is hemodynamic instability. If the blood seeps too much into the arterial wall, if the pseudoaneurysm is very large, it can cause hemodynamic instability, systolic blood pressure less than 90. Second thing, this pseudoaneurysm can compress the surrounding nerves, which can cause neurologic deficit. It could be sensory or motor if it's an expanding hematoma. If the hematoma expands such that it starts causing skin and subcutaneous damage. The reason behind this is that the pseudoaneurysm can put pressure on the dermal vasculature, which lead to ischemia and which can cause damage to the skin and also due to direct mechanical damage from the pressure. And the last, the pseudoaneurysm is a good source for bacteria to grow, as there is some amount of blood stasis, so it can cause symptoms of soft tissue infection like fever, cellulitis, or purulent drainage from the skin over the pseudoaneurysm. Now, if you see a patient with typical history of pseudoaneurysm having the risk factors, a similar presentation, the first and the foremost thing is you have to do an imaging. Only a good history and physical exam is not enough. You have to do an imaging. So if a question comes on the exam which has typical history of pseudoaneurysm and also there is a systolic bruit, and if directly the treatment is written as well as an investigation is written, the first thing you will do an investigation. You cannot go directly on the treatment regardless how strong your suspicion is for the pseudoaneurysm. And the first line investigation or the imaging is the arterial duplex ultrasound. The second line investigation that can be done is a CT angiography or catheter-based angiography. The catheter base should be done from the contralateral femoral side, and then you access that as you go up into the iliac artery and then you come back. Now these are second line investigation, CT angiography and catheter-based angiography, and you do that when the ultrasound is equivocal, but you have a very strong suspicion. Or second, when the ultrasound cannot be used. For example, if the person is too obese, or if there are anatomic issues, like if a high arterial puncture was done. Because if a high arterial puncture was done, the ultrasound has limitations compared to a low arterial puncture. So what an ultrasound shows if there is a pseudoaneurysm, as I have shown this diagram, This black is the pseudoaneurysm, and this white is the lumen of the artery. It is called a yin-yang sign. It is a classic swirling bidirectional color flow. Now, how you manage a pseudoaneurysm? So, first of all, after investigating, we need to make sure that if it's an uncomplicated pseudoaneurysm or a complicated pseudoaneurysm. If it's an uncomplicated pseudoaneurysm, we see what's the size of the pseudoaneurysm. If the uncomplicated pseudoaneurysm size is less than 3 centimeter, we only observe, and then we do interval duplex ultrasound every month. Now, when you go for an intervention, the first reason for intervention is if there was an uncomplicated pseudoaneurysm of less than 3 centimeter, and now it shows signs of enlargement, or there are signs of symptoms. For example, pain, fever, hemodynamic instability, or after 6 weeks you still see that the pseudoaneurysm is persistent, then we go for an intervention. If the pseudoaneurysm size, whether symptomatic or asymptomatic, is more than equal to 3 centimeter, we go for an intervention because it's very unlikely for a pseudoaneurysm more than equal to 3 centimeter to go away on its own. So regardless of the symptoms, regardless whether it is complicated or uncomplicated, any pseudoaneurysm more than equal to 3 centimeter needs intervention. Now, if the pseudoaneurysm qualifies for intervention, the first line intervention is ultrasound guided thrombin injection. If ultrasound guided thrombin injection, that is, you put thrombin into the pseudoaneurysm so that it closes, and it's ultrasound guided. If it fails, then you repeat that. But if it's not available, then you can go for surgical repair, and also you can go for endovascular repair. But the first line intervention is an ultrasound guided thrombin injection. Now, if the pseudoaneurysms are not treated, what complications can be there? Number one, local pain can be there. Second, it can rupture, as the blood can also seep past through that periarterial connective tissue, and this pseudoaneurysm can rupture. The third thing is this pseudoaneurysm is a source of bacterial accumulation, and it can cause sepsis and abscess formation. Pseudoaneurysm can also cause thrombus formation, and it can also lead to distal embolization. Pseudoaneurysm can cause compression of the femoral nerve by pressure and can cause neuropathy. It can compress the surrounding skin vasculature and can cause ischemia. The last complication of cardiac catheterization is a hematoma formation. It typically is of two types. Number one is a localized hematoma that can form, and the second hematoma is a retroperitoneal hematoma. If it's a localized hematoma, it presents in the form of a mass. There's a large area of ecchymosis. but it can or cannot have a bruit. Majority of the localized hematoma resolve over a period of days, and you don't need to do any investigation or management other than observation and only manual compression. The advice that is given is to avoid strenuous activity or lifting heavy objects within the first week, the same we gave for pseudoaneurysm, to decrease the activity after femoral artery catheterization. However, if after femoral artery catheterization there is retroperitoneal extension, now this is a problem. Majority of the time it occurs if you puncture the artery above the inguinal ligament, because then the blood passes into retroperitoneum, and it usually occurs within 24 hours of the procedure. How it develops: as the blood seeps and accumulate, it causes hypotension, tachycardia, and as the blood accumulates in the retroperitoneum, it causes ipsilateral flank pain, typical symptoms. Now, very important, if you suspect retroperitoneal hematoma, the first investigation that you can do is a non-contrast CT. It's a non-contrast CT or abdominal ultrasound. Both investigations can be done regardless of the hemodynamic stability. It's very important to know that this is a retroperitoneal hematoma post femoral artery catheterization. In case of a spontaneous hematoma formation in the retroperitoneum, in patients who are taking anticoagulants like warfarin, the choice of investigation is contrast CT. However, here it is non-contrast CT scan. Now, how you treat? So if there is no active bleeding, that is, you do not see any active extravasation on the CT scan, or you do not see any bleeding through the wound, you just suggest bed rest and blood transfusion. However, if you see that the bleeding is active, for example, there is extravasation on the CT scan or there is bleeding from the wound, then you do first percutaneous methods. For example, you can try to inflate through a balloon, or you can put a covered stent just to avoid blood loss into retroperitoneum. However, if the patient develops hemodynamic instability, or you have already transfused more than 2 units, 2 indications. If the patient develops hemodynamic instability or you have transfused more than 2 units, you go directly for surgical management, that is vascular repair. Now, you do not go for percutaneous methods. Another thing you have to do is that if the patient was on anticoagulants, then you have to reverse systemic anticoagulation. It can be done by prothrombin, complex concentrates, vitamin K,